So should we start, I guess? We have all the panelists here. Good evening, all. Thank you for joining the fireside chat on Demystify National Health Stack for young startups. Before we start the session, I would just like to highlight we'll be taking the Q&A at the end. Kindly, if you have any questions, there's a section called Q&A. Kindly post your questions there. The moderator and the speakers would be taking it at the end. Before I start, before we start the session, I would like to introduce the moderator for today. We have Neeta Tyagi, who has more than 27 years of varied experience as an entrepreneur, executive roles in global organizations and in the social sector, working with the government on population scale transformational programs. Currently, she is engaged with two national level digital platforms with EGA Foundation on urban governance as engagement lead for the state of Uttarakhand, and also with iSpirit on healthcare digital platform. Thank you, Neeta, for joining us today as a moderator. I'll hand it over to you. Thank you.
Thank you, Ghazal, for that kind introduction. Let me introduce the audience who have joined us today to participate in the demystification of National Health Stack. And the format here will be, we'll have 2 rounds of conversation, 15 minutes each approximately. And the first round will take you more through the genesis of National Health Stack, what it set out to solve, the challenges, the design, the utility of the design. And the second will be more about the ecosystem required for its adoption. And that ecosystem includes the startups, which is you. So the focus will be a lot on the opportunities for this section. And thereafter, we will take your questions and answers. And let me now introduce the 2 specially handpicked speakers for this session. We have Kiran Anandampillai, who is joining us from Goa right now. And he is literally 3 in 1. He is firstly my co-lead at iSpirit for the healthcare track. He is also the technical advisor for NHA. National Health Authority is the one which is entrusted to for the implementation of National Health Stack under National Digital Health Mission. And thirdly, he's also a service provider who runs a chain of eye care hospitals in more semi-urban, rural, Karnataka. So he has that perspective as well. So very warm welcome to you, Kiran, and thank you for joining us. And then I have Abhimanyu, who's the young, dashing, entrepreneur who's joining us from Pune. He's the founder and CEO for Live Health, and one of those startups which very early on sort of engaged with National Health Stack. So his experience is the one which will be most relevant, I guess, for the audience today. So let's get started with our first round. Kiran, do you remember that day in March in 2017? I have it as crystal clear here, where a dozen of us met 6:30 in the morning in Koramangala, and to meet up, and our first to do something in healthcare, obviously. And our one line brief was how technology can make these, the government, production schemes, the money that is allocated to them, reach the intended beneficiaries successfully. So this is something very unique to India, as you all know, even though we may end up fighting that the money allocated is very less, but the fact is even that doesn't reach out to the intended beneficiaries. Or like today morning, I was reading the news and it said a scheme in agriculture, some 1,400 crores money went to people whom it was not intended to. So I think this is something very unique to India, and therefore, the Western solutions don't really sort of fit into it. So anyway, as we used to meet regularly, 6:30 in the morning, in fact, our project was called Project 6:30. I'm going to share a real story, which may be a bit anecdotal, but guess it resonates well with most. So very early on in this, project, I was talking to a gentleman from insurance company. He is from the field, and he said, Neeta, if you're into this, you need to first understand and have a mental image of the beneficiary, what it looks like. And this is what he painted for me. He said, imagine this woman in the interiors of let's say, UP, Bhagwanpur, her name is Lakshmi. She's about 45, 50 years old, but looks 60, 65. And basically she puts dinner on her table by selling the betel leaves, which she goes into the woods to, look for. And she has a grandson to look after with no other, member in the house to, add to the income. When something, and Lakshmi is the beneficiary, intended identified beneficiary of the National Health Scheme or the Mukhyamantri Yojana, etc., whatever. Now, when Lakshmi falls sick, what are the options in front of her? Does she take the transport, the bus to the nearest, town to get access, which means that she has to spend money plus lose out on that daily wage, which puts dinner on her table, or she continues to suffer, or she goes to a quack, nearby. So basically, what we're seeing is that even though there is money, promised to her, she doesn't have affordable access. Now, given her, let's say it is a good luck that there is this doctor who moves from Delhi to Bhagwanpur, right? Because he belongs to that place, he's good-hearted, he wants to serve the people, right? And when I talk to Dr. Pradeep, he's a known person to me, and and he has basically participated in most of these schemes again, and so much so that he has actually collected, or he's basically, government owes him some 7-8 lakhs. And this is what, makes it difficult now for him to treat this woman, because much as he wants to, when Lakshmi comes to him, he says, look, if you have got money, which is what we say the out-of-pocket expenses, right? I will treat you, otherwise, you can go back to the queue, and if I have time, etc., then I'll pay you. Cut to now the insurance provider. What is his story? Basically, he says, I don't make money on this, and at least I don't want to make a loss. I have to identify, right, whether this claim is coming from a ghost doctor, a ghost patient, is it a ghost procedure, and all that costs money. So basically, the costs are so high, and that explains the conservative behavior. But basically, what we see is, I think what's interesting here is that affordable access is not the issue just for Lakshmi. It is actually an issue for the service provider, as well as the insurance provider and the government. Would it not? The question to ask is, would it not work, right? If doctors have access to 1.3 billion paying patients, and if the cost of providing insurance for the insurance provider is low enough that they can expand their business. So really, I think what we see is that if we peel it further, what we find is, mistrust. We find, frictions. We find high cost because of fraud and, operational sort of, issues, and also misaligned incentives, right? Add to this potpourri another potent ingredient of missing quality, which even if you and I are able to pay for it, we don't get. And when I talk to entrepreneurs, I think most of them have a personal story which got them, into this health tech space in the first place. So what we are really talking about, the challenge is, what will put these 1.3 billion Indians at the focal point, making them power payers? And that's the word, power payers, that they can spend, whether it is government or whether it's their own money, they can pay for that. And once that is done successfully, then we will be at par with the Western world, where now the question of high cost comes in, right? And for this cost to be controlled, you need to have a wellness instead of an illness orientation. So the challenge is how to drive all the stakeholders to health-seeking behaviors. Second challenge I would say is, we discovered is that healthcare, someone said healthcare is like politics, it's very local. So what works, for example, in AP, what works in Karnataka, what works in Tamil Nadu might not work, and I'm referring to assurance in this case, might not work for some other states. So what do the policy makers, how do they see the impact of what they're doing, and how do they course correct? So which means that data needs to be there. And I must mention here that when we were researching RSBY, all the data that was available was post facto. You go to the villages and you ask people, how much do they remember, etc. So, there's no way. And I guess the third thing is the complex landscape of healthcare, where multiple problems occur at multiple levels and they demand local solutions and at scale. So the challenge is, how do we catalyze the ecosystem, both public and private, and distribute this capability to build solutions? So Kiran, I think now I would like to, rope you in to talk about, from technology perspective, what are those 2 or 3 design aspects baked into the national health stack that promise the resolution of challenges we just identified?
Sure, yeah. Thanks, Nita. And I think since you're talking a bit about the history, I think most of you may or may not know that the evolution of the thinking on the national health stack actually coincides with the launch of Ayushman Bharat. In fact, the group presented its viewpoints that Ayushman Bharat's technology, which was actually the government announced the Ayushman Bharat scheme in 2018, should actually be built on a foundational infrastructure that we had called the national health stack. So the idea was build the stack, build Ayushman Bharat on the top. In fact, didn't go that way. The government was in a bit of a tearing hurry. So they built the technology for Ayushman Bharat first. And now with the National Digital Health Mission, we're just about starting to build the stack. We're happy to share that Ayushman Bharat is definitely one of the first adopters of the elements of the stack. But fundamentally, at the core of solving many of these problems with technology, right? Of course, we all understand that technology is not the only solution to the overall problem. It's just an enabler. Is the ability to first unlock data, health data, so that it can actually move between various participants, so that there can then be value added on the top. So unless today we all know it's all siloed, everybody keeps it in their own. The best example I have is, during this COVID period, I had a COVID test done. It was a beautiful experience. I got an SMS on my phone. I could go to the lab vendor's website. I could put that SMS code in and I could see a PDF report of my test. So great that digitally health data was being shared with me. The problem is, in 5 years from now, it's not part of my history and it is not a machine readable information. So now the National Digital Health Mission is really saying that, look, you are, as providers, as lab providers, Abhimanyu is runs and can talk on behalf of probably many labs. The push to start sharing information, health information digitally with your patients is already there. Many lab reports, discharge summaries are already digitized. The question is, can we provide an interoperable national architecture that allows for this to become part of a longitudinal health record and gets into your control? So you decide, not only can you see it, but you decide who you want to share it, for how long you want to share it. And so that really is the lower level fundamental building block layer that we saw as part of the national health stack, which is a very key enabler, a consent-based, user-controlled way to have all these health records in a federated manner move around in some way. So you can read a lot more about this, those interested, especially if you're building software for hospitals or labs. You should definitely go look at sandbox.ndhm.gov.in. The whole, how do you actually approach this problem? How do you do it with all these APIs is already there. Or if you're looking to consume this data, you could be building an app for a consumer where, you want to access the health records, or you could be doing a teleconsultation where, a doctor is requesting history and then sharing the prescription back. All of these are brilliant use cases for this kind of sharing. And all of this is possible today because of these layer. Now, the other bit that Neeta talked about, which is very important, is the construct. India is not one India, and there are hundreds of different local scenarios and use cases. And so the national health stack actually builds on a construct that at iSpirit we call as public goods private innovation. And I think you can see this best in some other bits, like for example, UPI. UPI is a service which provides a bunch of APIs hosted, managed by mostly public entities. And then there's a whole bunch of private innovation on the top, which has actually helped move digital payments to a very, very large number of people in this country. Very similarly, the National Digital Health Mission is going to build very few digital public goods. We call these building blocks, these digital public goods. All of them have open APIs, all of them have documentation, and it is designed for both public and private applications to come in and build on it, so that all of us can ultimately solve for the end consumer. And The other bit about this design, and this is the important part, as Neeta was saying, that we are not just building for one type of India, we have to build for the whole Bharat. So the solutions that we are designing needs to work for somebody at the top of the pyramid with a high-end smartphone to somebody with absolutely no phone. And you still need to be able to say, okay, I can do or build these kind of experiences for all of these. So I think happy to share that this is the direction that this has kicked off in. So it's very fascinating to see that there's been significant interest in the government, with the Prime Minister himself actually launching this on August 15th. So currently the government is actually running this as a pilot in 6 UTs. You're likely to see some national action with the COVID vaccination starting to go live. So there is some integration for as part of the COVID vaccination drive that's currently happening in the country. So this is something which has been designed to be open to anybody. So all you need to be is a registered entity in India to actually participate in this new health data ecosystem. So I'll stop at that, and we can answer more as we go along. So point you to, please do look at sandbox.ndhm.gov.in, and it's a pretty good place to get started if you're interested in this space.
Thanks, Kiran. And probably now I would like to call on Abhimanyu. Abhimanyu, would you like to share with us and validate or otherwise, the challenges that your startup is solving? And, do you resonate with this discussion so far or not? And what aspect of the design of National Health Stack actually boosted your startup? I think that'll be very useful for the audience.
Sure. So, well, I think the first call we had with Sid and Sharad, that itself actually got us quite interested. Maybe slightly zooming early when we started. Actually, when we first started Live, what we were trying to solve was, how do you improve patient experience from the provider and kind of give more value from provider to patient? And our first understanding of this problem was we'll have to build a lot for patient-provider communication and very little on the provider side. And the minute we started talking to providers, we realized, okay, how do we get the data? We'll have to integrate with providers. How do you integrate? Every provider has a different way of communication and different way of storing and managing data. And it was at every point of time, we were actually discovering so many layers of this data and being fragmented all over the place. We ended up becoming a B2B company in the end, and barely having little action on the patient side. And well, that is how we actually came about. And then we actually kind of morphed into this idea that nobody else should actually go through this. If someone's having a Live powered software running in, interoperability should be taken care of. And we actually built a lot of interoperable ways internally, as well as connecting with many of the players in and outside India as well. And in this, when we first heard about the National Health Stack, and actually a few years before this also, there were very little action discussions happening around what could be built, how could interoperable systems work like in India. And we were actively discussing, but I think there was where we are right now and what was being discussed before were quite different. And I still remember the first call I had with Sharad Sid and a couple of other folks in the call, explaining the entire health stack. Was actually, this is exactly what we need. This is exactly what we should have had long back, so that a lot of startups, not just startups, but a lot of innovation actually doesn't have to struggle through aggregation, managing interoperability and also managing transactions. They can actually build value. The way we saw this was we actually spent a lot of time building the backend where the front end itself was compromised. And we spent years on this. And, now when we see the opportunity for, the startups and what people can actually build with all this data being available, it's a lot of things that we've not even seen right now. I'm sure so many other startups already in healthcare or struggling through the same set of problems. They have to worry about organizing data. They have to worry about, interoperability of data. And this is so constant, and healthcare being so complex in every transaction, in itself being unique. Like, Kiran talked about like lab reports, discharge summaries, and in lab reports, there are like hundreds of different formats. And same with discharge summaries, same with clinical transactions, and so on and so forth. There's just so many different diverse ways of information. And most of this ultimately gets boiled down to like files, which are those PDFs, and most of it is not machine readable, so you can't build on top of it. So you need people to extract value out of this. And often a lot of companies, like even insurance companies and people in between, actually try to create value out of that, by having like army of people doing this. So it's not scalable, right? And I think at one point, I think everybody understands that this has to be solved. But the issue being, it's not. I think the good thing is startups don't have to worry about interoperability anymore. They don't have to worry about building tools for interoperability. There is a standard, and I think there was a lot of debate on the standard itself. But then there is a standard. I think there is now a standard and a protocol for communication, and there is standardization on panels, and there is standardization on tests, which all in all actually gets us everyone on that one single level playing field, where, okay, now let's build value. Now let's talk about value for patients, value for providers. How the end patient user experience can improve. Also, how providers can now actually extract like better value of their operations, right? I think the entire experience is much enriched with the cross, like interoperability of information in general. I think that's the that's what I would say.
Thank you, Abhimanyu. I think you put it so well, and it feels great to hear that, because I think this is exactly the what we were thinking about, when National Health Stack design was put together. It's almost like on your, how we see the way we travel has changed, whether we take a cab or where we live, Airbnb, etc. And each one of them has solved a very specific niche problem, but none of them had to build those basic blocks available to each one of them, which is the GPS, which is the payment gateways, etc. So absolutely, I think that this really hits it on the nail on the head, that National Health Stack wants to catalyze, these solutions at speed and at scale. And this is what we all have actually observed in our lives, in other areas. So anyway, now this brings us to round two. And like Kiran said, technology is just an enabler. You need the policy to back it up, and you need the entire ecosystem. And that explains the journey of National Health Stack to National Digital Health Blueprint, from what to how. And then the National Digital Health Mission, where basically, was a result of interministerial committees and, public consultations, with the domain knowledge, what institutional home will be there. So that is what we have seen. But coming to, my favorite topic here is adoption. Just because there is a building block, right, doesn't mean that it will get adopted. For that, we're talking of humans here, right? How to, solve problems. And startups, in my mind, are one of the biggest stakeholders of this ecosystem. So we will really, basically to have a sustainable impact, we need to tap into their collective energy, and that puts startups in the spotlight. And I believe that it is not possible without your collective energy, to work on this. The story doesn't end with the building of blocks, it rather starts from here. So, and I think, for example, we have doctor registry. Now, why would doctors get onto it? I mean, what is the problem that is being solved for them? What is the user experience? So these are number of questions, which come to mind. And Kiran, I would like to now, share with the audience what all has been done. So for example, there is this NDHM PHR app. I mean, it is there. But what does the startup community need to really do so that the adoption happens. I think it'll be great if you put both your NHA hat on and then your service provider hat on to, tell the audience which has these young startups where they should look for, what they should focus on.
Sure. So I think, Neeta, it's a very good point, and I think it's very important to understand where the opportunities are, especially if you are an entrepreneur, you're starting up now, what it is. And I think Abhimanyu is a classic example of identifying one of those opportunities, right? So because if you generally look at, we are talking about digital healthcare, and if you really look at India, India is really a very, very large number of very small, actually, healthcare providers, right? So, the corporate organized sector is extremely tiny, and there is a very large number of individual either labs or clinics or even hospitals run by individual doctors. Almost 95% of healthcare is here. And Abhimanyu can vouch for this, and I can tell you that most are not technology savvy, right? So they understand that technology is important. I mean, I think today you can think of any business in any field, technology will play a some role for everyone. And this large segment does require a whole bunch of new energy players who will service that. You can think of it like in when at the point when Demon happened, I think the first thing that all these payments company did was to go sign up the Pani Puri wala with that little sticker so that you could make the digital payment, right? So really organizing the unorganized in some sense, but you had to do it with technology. You needed a bunch of standards, you needed that interoperability so that that same scan could scan for anything. At the same time, you did need some set of players who would actually go into the market and actually sign up and help service many of these providers. So I think there's one big opportunity in being able to help use the fact that now not only can you share health data from whatever you are creating to make your experience with the patient far more digital, but also see how you can use the incoming data to provide better care. As medical history starts to get built, you're going to need a new bunch of software that's able to take in that data to actually look at it and say, okay, look, Mr. Oncologist, this is based on the history of this patient. Here is, I think, what you should be doing, right? So I think the opportunities are there. So whether you want to, so I think one area that people should take a strong look at, especially if they're playing in the solutions to either providers or players, is that extremely important to look at what are these new set of standards that are looking to unify or bring this data movement in and make sure that they are delivering on that. The other bit is especially in terms of people who want to consume the data for different purposes. You can think of from a consumer perspective. India is the world's largest diabetes population, and imagine how you can actually nudge them to actually take care of their health better if you had also access to their health information, right? And that can actually be done by a new class of apps. You can think of it in any specific vertical that you can think of consumer apps that can help individuals with access to their health data. And then there is a large number of B2B cases that are based on health data that I'm sure a whole bunch of people out there are trying to solve. So I think in many ways, NDHM is really going to create a very large number of different opportunities in applying health tech. And we did not even talk about what's going to happen with health insurance and health insurance processing. With the claims platform that's coming in shortly, we are essentially saying that there'll be, and I don't know if you have ever gone to any large hospital and taken a look at what they call as the TPA room of the hospital, because for every insurer and every TPA, there is one guy sitting there saying, sir, if you're on my card, I'm going to help you process the claim on my platform or on my fax or my email-based solution, right? And so that's going to get standardized, and that's going to actually simplify a lot of things. And there is huge opportunities both on the provider side as well as on the payer and the processor side to actually improve claims processing. India is actually, 99% of claims in India are manually adjudicated. The cost of processing that claim is over 500 rupees plus in India. And so if you really are trying to get to universal healthcare, OPD cover, the cost of what we want to pay for a claim is probably $400, consultation plus medicine. And so you're never going to get there unless you're actually going to be able to apply all of these technologies to create solutions for auto adjudication, for fraud detection. we are looking at how can there be faster and simpler e-prescriptions. It's extremely important that doctors be able to create a prescription and e-prescription, be able to share it with you, make it part of your longitudinal record very rapidly. And I think there's significant opportunities for all of this, and we are really looking at the entrepreneur community to develop this. I think saw some fascinating ideas in the last healthathon that happened, real interesting innovation that's coming in. So I am personally quite excited, and it's also reflective that on the NDHM sandbox, we have had more than close to about 500 applicants who have applied, got access to those, trying to get access to those APIs. I think we are the approved number of guys that getting access to those APIs is about 350 or so right now. So I am very confident. And then there's a whole bunch of people who are actually managing to finish the integrations and starting to go live, like Abhimanyu. I think I saw a chart in some review today, Abhimanyu, with, you had, you're like a couple of days from taking it live in a few units. So, good show there, and really good job in, kind of going through those integrations. So I think the timing is now. On the adoption curve, Neeta, I can just tell you that, there are two things for entrepreneurs, right? You can either be one of the early birds, say that, look, I can sense that this is opportunity, this is coming, but I can tell you a bit about how the government is thinking about this adoption curve, right? So there are three areas that the government is strongly focusing on. The first cohort or the first group of people it's focusing on is public healthcare. In an year from now, you're likely to see every public hospital, whatever software they have, it's going to be issuing digital records, it's going to be able to share history with you. Think of AIMS, think of all of these government hospitals out there, all of them are going to be doing it. Every large national digital health program, whether it is the mother and child program, whether it is the TB program, whether it is the NCD program, they're all going to be capturing data and sharing data digitally. So public health will probably touch almost 100 million people within the next 2 years with digital information. Large organized corporates are already adopting this. We have integrations ongoing with every big corporate you can name, Apollo, Narayana, Dr. Lal Path Labs, all of them. And between them, a whole bunch of others will start experiencing digital care. And lastly, we are working with every large provider of EMR, LMIS, and EHR software in the country, right? So India, we don't, unlike the West, in the West, if you go, you probably have two large players you have to deal with. India is like hundreds of different software players who service this very fragmented market. And so many of them have already started these integrations and going on. So we are likely to see, and my own expectation is that it will really start touching each of our lives within the next 2 years. And so if you're an entrepreneur, you know that if it's going to come in 2 years, this is the time, if you're in this space, that you got to start looking at this deeply and start saying, okay, where are those, where does this fit into the overall scheme of things that I'm working on? Thank you.
Great. Thank you, Kiran. And Abhimanyu, probably you could share from your experience, to drill upon facets that the health tech startup should focus on or be wary of. I think you had some stories about, how the problems are defined, or, even about tier 2, tier 3 opportunities. So anything that you would like to tell the audience from your experiences?
Sure. Well, when we started integration, I think like the integration is actually fairly straightforward. It's ideally, like a tech-based company shouldn't take more than a couple of weeks at max, and of course the user experience needs to, then I think the remaining time should be spent on how do you make this like really easy for customers to adopt, because ultimately adoption is like the golden metric. We saw, like, just to share, we saw two challenges. One, the tech integration is actually, in fact, quite straightforward. The protocols and honestly, like the things even we have to integrate are very minimal. Most of the data still resides on the provider side. And, wherever there is an authenticated request, we just send the results or link the patient. Challenges actually happen when, how do you sign up providers on the platform, right? Because this is pretty much early for it. This is the first connection for everyone: the provider, the doctor, the gateway, the bridge actually. So it's the first time for everyone. So that I think like people need to think about signing up providers on the platform as well. We in fact in the UTs we actually identified some of our centers and actively spoke to each one of them and told them. Of course, the BCG team was there to kind of support and actually do the discussions and got them signed up. And once we had them signed up, we could really start showcasing value on each and every patient that comes to your center now can actually get this data online. And this would significantly compound over time as there's a PHR app soon, and then eventually people can actually start seeing their past records from other public hospitals, and the ecosystem will then start building itself. I think the bigger challenge in terms of development lies ahead, which is how do you make sense of this data, like Kiran talked about. And that's going to be the bigger challenge that people would take about a year to solve, really well solve this. One being standardization of that data sets, even though there is a protocol and there is a general, a chalked out standard for results and the structure of the data. It is the variables are still quite a lot for it to be programmed in the application. So that's going to be a bigger challenge going forward. And then, of course, like further on, making sense out of that data and delivering value to like patients or doctors consistently. And whether that's through whether that's for simplest of the things could be reminding patients for their medications, or even giving some smarter insights on their reports based on the results they saw, or just giving some health tips based on your past cholesterol reading, right? So like really simple things that can then now be built. And a lot of them actually in today's world, the benefit is you don't even need an app. You can just actually have a WhatsApp chatbot that can just do these things. And you can just forward a report and it would just get things on your messages right there. So these kind of, I think, benefits are there, but I think that people would still have to spend time organizing that data, because that's going to be one of the biggest challenges that I think the most immediate challenges startups are going to face. The good thing is now at least the doctors and providers signing up, are they actually doctors and providers in the ecosystem, right? I think that is a big fear that I think people I think underestimate that problem in India when they first start getting into this. But when they start signing up doctors, they start realizing that okay, he was not a doctor in the first place, right? So these kind of surprises wouldn't happen, and obviously no private company can successfully vouch that without a lot of investment into the system, right? So I think this is one of the things that the provider registry, we are actually very, very positive about it, because we still don't know how many labs and hospitals and clinics are there in India, right? People throw numbers and their estimates, right? But how many are there really, right? Like, because we often see multiple different trends when we actually go in the market. But then the top level numbers don't add up. So there's this constant debate on, how many centers how many transactions do we do? What are the public-private transactions happening? So these kind of things will now be more objective. And also working with public hospitals and public healthcare providers it will be much, much easier. You can actually build on top rather than building and going through the whole process of, public, tendering and these things. So, yeah.
Yeah. And I think that's exactly what National Health Stack intends to do, that you should not spend your time, energy, money in figuring out whether this is a doctor or not, right?
Yeah.
What all labs are there, kind of stuff. So no, great. I think I'm not sure if our time is up. We have more time, but basically, I think we are done with our 2 rounds of discussion as we had planned. And if there are any questions, from the audience, we'll be happy to take that.
I think there's one for Abhimanyu. So Abhimanyu, you want to take that? And I can check in if you want.
I think Well, standardization typically, the way we try to address that was through creating dictionaries. And one of the things we realized that multiple standards like the ICD or the Lowing Standard generally is not designed for the Indian data set or the Indian way of reporting results. And I think a lot of things have changed, and there has been like one standard under publishing from the NDHM itself. Internally, what we do is we created a master dictionary of parameters, and kind of get our providers ready to map that from one side, and on the other hand, any partner that's working with us also explain that standard to them. That creates a lot of friction, and I think almost all providers actually don't see value in tagging and identifying data, so that's a challenge. And we often have to put in internal resources for that standardization, which often becomes like a trade-off question: should we do this or should we do that? And in case of limited resources, I think the good thing is there would be a published standard for the tests, test master and parameter masters for laboratories. I'm assuming the same would extend to clinical data as well. And I think all together would kind of give that basic, starter for that, communication between that. So, yeah.
Yeah. Obviously, just to chip in on what Abhiman is saying, it's actually unfortunate, but even though there are specified standards, like for example, for lab reports, there's the Lowing Standard. It is not easy for developers, including like Abhimanyu, to quickly adopt. So one of the things that the government is doing, working with something called the National Center for E-Health Resources, is starting an initiative to actually make a simple data set that's easy for, say, any lab provider to pick up and say, okay, take their current list of lab tests that they offer in the market. And we think, we have had several discussions. It's not that we need to really, 90% of the work is in about 1,400 tests or so that probably, are part of the market. So this is one of the things that the government is trying to do, and it's trying to be part of the NDHM ecosystem. The other thing that it's doing with NDHM is providing time for the standards implementation. So the way it works in NDHM is it allows you to start with your data formats in like a PDF format today, so that it's still shareable with patients. It's still human interpretable, but that we know is going to be really difficult for machine readability. And these kind of startups will typically get only an year certification. And then in an year, we're going to ask them to say, okay, over the next year, try to make sure that the report outputs are more structured and more machine readable. And so we expect to see over the year improvements in how actually the data and the data standards move. But pretty much standards for constructing, whether it's whatever component of a healthcare report you want, already exists globally. We are mostly looking simply to take what is the right set of standards, make sure that there is a profile that's for India. Like for example, if you go to the NDHM site, we tell you that you should adopt the NDHM FHIR profile. So we took FHIR for release 4, which is an international standard, looked at the resources that are part of that and said what makes sense in the Indian context, and then essentially published a standard that says, okay, here is how you could adopt it. And we kept it flexible so that you can start with PDF documents, but move to structured data over time. And so that's the core approach. And I think you will see as you get into the space, there's a lot more effort that's going to go on this standards bit. And Abhiman is absolutely right. We are probably a couple of years or more away before reasonable amount of the data that flows on the NDHM plumbing is fully machine readable.
We have another question from Abhilash here. They are a privacy enhancing technology. I think the question is on the Q&A. And basically, they want to know how they can participate and contribute to National Digital Health Mission. I think I would say participation in the NDHM sandbox, but Kiran, is there anything else you would like to
Yeah, I think we bit early, and I think you can please write to me or Neeta, and we can also connect you with some of the people who are looking at the space. The thinking on the anonymization layer is in very early days. It's a good time to contribute. So there is a very nice discussion forum that's also available on Sandbox. So you can also air your comments there. There are people in the government who are looking at the kind of comments that come on the discussion forum. You can also write into the IDs that are published on the ndhm.gov.in website. They do take a look at some of these inputs, and somebody can schedule something to see what you guys are actually doing.
And I think there's a question from Pranav on similar lines. Basically, he's an aspiring entrepreneur, and therefore he wanted to know how National Health Stack could be utilized, integrated with their platform. Any insights on technical aspects for this NDHM service integration?
Well, I think I would say that the documentation is actually really self-explanatory. Essentially, in a brief, you have to integrate couple of points, a couple of triggers. One is when you actually create or register a patient, where you can you can search the patient via the health ID and just stack, or you can actually, if you have that patient already registered, you can actually link it on your platform with the health stack. That's largely the most important thing for linking the records to the health ID. There is an OTP verification step just to kind of double confirm this, and I think the implementation of the privacy aspect on the health stack is actually, from a patient standpoint, when you're accessing that health, it's really good. Like, I think pretty much any access or every time a patient's data is accessed, you are notified, and there is an OTP confirmation. So I think there are some really good ways on the privacy front for the previous question. But coming to this, I think once the patient linking is actually done, the only next big step is getting the data back, or giving the data back when it's ready, either in a PDF format for the provisional setup, or in a raw data format. That actually would require some amount of technical understanding. But I think for now, I think a good step is actually starting with at least getting to the platform, integrating with them for patient registry, and figuring out ways to give or get PDF data back and forth. So that should largely do it.
Yeah, and I think, Pranav, you have another question where you said, how does government want to go along with emerging entrepreneurs with NDHM and National Health Stack? And I think Kiran sort of answered that question in terms of, what efforts the government is making. Anything you wish to add, Kiran? Then we can.
No, I think that's pretty good. I'll just take a couple of other questions that I saw. There's one from Vaibhav, and there's another from an anonymous attendee on what's the role of people like Practo. So Vaibhav, I think we can look at healthcare in India in two ways, right? There are things that are absolutely not digital right now. So if you walk into any doctor, likely that they're always writing prescription scribbling out on a piece of paper and so on. But at the same time, it's very rare probably for you to see a diagnostic report today that was not printed on a computer, which means it was already produced in some ways digitally. So in many ways, we think the first step in NDHM is to go after things that are already digital. So we think the things that are mostly digital in India today are diagnostic reports. And we think working with a small set of players, you can actually quickly and rapidly standardize that for a large number of citizens. The second area is actually discharge summaries. A lot of good organizations today type out actually their discharge summaries in an electronic format. And then over time, we think, OP consultation notes, prescriptions, and others will actually follow. So entrepreneurs, in many ways, there is a real opportunity to actually say, okay, how can we improve, the digitization? And I think this pressure is going to come. Imagine that most top hospitals, most public providers are starting to share after your health visit, you're always going to get data digitally. it is going to put pressure on the rest of the system to follow. There will be a demand for digital sharing of information with time, and I think that's something that you should bet on as a direction that it goes. In terms of what Abhimanyu was talking about, the NDHM architecture is something that we call as a federated architecture. That means that data largely stays at the provider that created it. So if you are the software maker or the software supplier to that provider, then you can play the role of what we call as a health repository provider. For example, Abhimanyu's company acts like a health repository provider for up to almost, I think, I don't know what, 4,000 plus labs, Abhimanyu now. So it can act as a single software entity. So when Abhimanyu makes his software NDHM compliant, and his lab guys don't really need to know the details, they're still going and saying, okay, I'm going to do a complete blood test count. Just the fact that, they continue to get the PDF in the formats that they want. But when Abhimanyu's software starts sharing it with patients, it can be in a standardized format, right? And that's really where we are trying to make this go. So people like Practor, anybody supplying software to hospitals and labs are extremely key to this ecosystem. We are looking at them having variety of roles. So, it doesn't actually change. It actually makes their role larger, and the opportunity for them larger to, answer the question that's out there. And to Pranay's question on mandating, by design, if you read the policies that have been published on the National Digital Health Mission, it is designed to be completely voluntary, which means that it's all the more important for all the players in the ecosystem, including the government, to figure out what are the incentives as to why people will participate. Why will lab participate? Why will a hospital participate? Why will a consumer participate? And so on. So finding those incentive reasons is also an extremely important part of it.
Just to add to that, Kiran, I think given that I also work with the National Urban Stack, in states, and when I sit with them and have these conversations on, because it's not very straightforward. You go to a state and they say, yeah, we will kind of take it up. But I found a lot of resonance when you tell the states that, look, because this is a kind of a platform structure, right? I mean, these are the building blocks on which people actually innovate. Any innovation that is done in any other place, any other state, is actually available to you. So you don't have to make duplicate efforts to solve issues. And I think that that's a very powerful, which I found, states kind of really taking that as a positive point, that they can solve the problems that their state has with somebody else, building on the solution. Any other question that we have you would like to take up?
I think maybe Kiran, your thoughts on this thing. What kind of startups or tech service providers may be redundant because of the health stack?
Well, I can't actually think of one. So sorry there. Actually, I see opportunities for almost everyone. So it's, of course, it's a shift in the business side. I actually see opportunities for also a whole bunch of new class of players. It was very interesting that somebody brought up the fact that they're working with anonymization and privacy, right? So it's going to be very, very important as, we have only talked about what I call as personal data flows in the National Digital Health Mission. We are talking about how do you move health data from one person to another entity with their consent. NDHM also has a whole lot of other things which is to do with aggregated data and anonymized data sets. And so I think, we didn't get time to discuss that, and maybe that's more for the future. But fundamentally, I think between all of these class of things, I think it's really going to open up a lot of new opportunities for a whole bunch of players.
I think during one of our interview discussions, like we were discussing that we can't think of one bad or con for the implementation of health stack, right? There's just pros, like throughout. There's actually no con of doing it. There's no reason not to do it. Especially for tech startups as a whole in general, like just like a benefit.
Yeah.
Great. Thanks for that feedback, Abhimanyu. Really positive.
And I think there's a last question here by Joy Neal. I think, which are the best markets, countries for the things that the National Health Stack is trying to achieve, as in they are already running something similar successfully?
Yeah, I think there's been a lot of comparison on the different models of various countries, Neeta, and I think the level of user control that the National Health Stack has prescribed is actually fairly unique to India. India is very different. The way healthcare is delivered in Western markets. Whether you take the US, Europe, you take other countries like Singapore, where for example, NHS UK is it's highly digital, but it's also very public centric because it's all public driven. US is another world which I'm certain none of us want to copy in terms of how healthcare is delivered. But India really is pushing the curve when it comes to its PDP bill, as well as in terms of how it's viewing digital consenting. I think it's a very new area. And in fact, I did see a question, and it is a problem area that is yet to be solved, which is, we are in many ways saying, look, we're going to do everything with consent, and there's going to be a language to express these consents, which is a digital language, which makes it very powerful because it's a machine readable language. But the question of how well can everybody in India understand consents? What are the safeguards so that some rogue doesn't over consent and start harvesting data? And I saw a query where somebody say, can I pay people and collect their consent, right? So these are the precise things that we have to watch out for, because we do believe it will happen. So any good technology, Abhimanyu talked about the pros, I'm talking about the cons, because, from my perspective, I need to be worried about both. I can tell you that there's a lot of thinking going on within the government, within a whole bunch of people who are interested in this problem, to make sure that, because we have experienced this on phones. When the apps initially came out, everybody bought up a term sheet saying, this is what I'm going to do with your data, press here. And how many of you even read that, right? All of us just pressed OK. And that is dangerous. And I think you are seeing a shift as people understand the power that these this one have. Yeah. And that's still a literate thing, and we are talking about an architecture that should be able to service somebody who's that literate and somebody who is not. And so I think there is some good distance to go in terms of especially the evolution of making sure that consent is easy. There's protection, even if you may have, and there is safeguards so that rogue actors cannot really, misuse the overall architecture of the system.
And that is probably where we need a bit of startup energy as well to kind of figure out, solutions to that. Because like Kiran, you said, somebody has a phone, somebody doesn't even have a phone, but still, things have to go on. And I think just to add to that National Health Stack question, in different countries and markets, I would say that National Health Stack is a very, very indigenous solution, for India looking at its problems. But at the same time, when we did our research, I think I can probably say with some confidence that there isn't a country, at least the size of India, which has solved the problem of affordability, access, and quality together. And National Health Stack is something that we feel, if it is successful, will be leveraged worldwide. Because, like I explained to you earlier, our problem is that our costs are not high. We are not spending money, right? So the initial bit is about how we get that adoption in place, how we increase that trust between the patient and the government and the doctor that they will get treatment. It will be a very, very happy space if we are able to do that. And then we come to par with what the West faces in terms of running cost. Now they're bleeding, right? And National Health Stack is also, there is the design aspect is such to take care of. Obviously we need to work on that, but this is what I'm talking from the design aspect. It also talks about how to stem that. And this is in works right now. The how part is still in the works. But, I hope that answers the question. Is there any other new question on the?
I think one is worth maybe talking about incentives for service providers to join NHS. We, I think, talked about it.
Abhimanyu, you're asking a question or you're answering it?
Actually asking a question.
Sorry.
So it is evolving, Abhimanyu, and I know in the US when they wanted to encourage physicians to adopt under Obamacare, they put up actually a fairly large few $1 billion on that budget. Unfortunately, we are not yet there in India. But there is talk about how to actually do something. So, you never know.
And actually, I think service provider is one of the biggest levers. If they lean in, right, into this program, I think, that's the only way that people can get healthcare with money promised by the government or what they have. So definitely, I think these are the incentives that need to be, in terms of how does the service provider benefit. So for example, we are talking about the service provider doesn't get money on time, right? So if National Health Stack can solve that problem, can I get my money? Because right now the question is not when will I get my money? It is the question of will I get my money, right? I'm talking of pre-Ayushman Bharat sort of, era, where when I spoke to doctors, it was, and Kiran, you yourself have been a service provider, right? With some fantastic story about invoking Japanese gods to get your money, from from the.
No, I think that scenario is rapidly improving for sure, Nita. And I think we'll
There
see
will be
more
incentives
as the
for
and we'll see more as the claims platform comes in.
Yeah. Okay.
All right.
We'll be guided by you, Ghazal, in terms of, bring this to closure.
Yeah. For the closure, of course, I would like to start thanking all of you. Thank you for taking out the time and sharing the insights with the entrepreneurs and with the startups here. With this, I would also like to take a minute to talk about the initiative at CICO, which is Bharat Inclusion Initiative, where we support startups who are doing meaningful solutions, who are developing meaningful solutions for the lower and middle income customers in the area of financial services, skill development, livelihood, and healthcare. Under the initiative, we have one of the program called Office Hours, which is a 45 minutes to 60 minutes long virtual online mentoring session, where we have experts from within our team and our extended network, where the mentors provide advice on pro bono basis with respect to the challenges faced by the entrepreneur or the startup. We try to identify the mentor on the basis of the challenges. With this, all three of you have graciously agreed to mentor few startups. For that, the startups, they need to register. I've already shared the link in the chat. Once they register, they share the challenges. We'll try to map it as per your expertise and the challenges they'll be mentioning, and we'll be in touch for the same.
Sure.
Sure, Ghazal.
Thank you, Ghazal.
Okay.
Thank you so much.
Thanks, everyone.
Thanks, everybody, for joining in, and good night.